This is a patient that I initially did 4-level OLIF. The surgery was done about 2 months ago, and we did a 4-level fusion that corrected the scoliosis. And here are the pictures actually from last night. So the scoliosis is corrected. About a month after the surgery, patient fell, had a bad fall, and as you see, the cage here has migrated anteriorly, and I'm going to show you the position of the cage. All the other hardware are in good position, but the cage in the L4-5, it makes sense, it has more stress on that, has migrated almost completely out. And then actually, because of the collapse of the vertebrae, patient has very severe L4 and L5 radiculopathy. And here again, you see the problem is that the entry point to the cage actually has subsided into the bone. And to fix that, the options are going anteriorly, ALIF, or but then you have to do front and back. I decided to do this procedure all through a minimal invasive approach. Practically, here as you see, we position the patient prone through the same left transcambine approach. I first enter the disc under neuromonitoring, and then put a portal in. After dilation, here you see that the dilation and the portal goes in. First I tried to catch it, but really that instrument wasn't strong enough and it wouldn't give me a good bite, and so I abandoned that. And then here as you see, I tried to pass a K-wire, but the opening is so buried that it was really difficult to do that now. And I tried it a few times, and the cage is right now actually completely out of vertebral body. So what I tried to do then was to put a really like a sharp bend into the wire, K-wire, and corkscrew it into the cage. And as you see here, after 2 attempts, I'm able to corkscrew this wire inside of the cage. Here you see that now it's going in and practically screwing around that. And here you see that cage is completely loose. Now that I'm inside of the cage with the wire, I put a threaded rod that is part of the inserter, and I literally put about half a thread in. When I try to pull it back, it disconnects. So I have to do it, but the problem is that because it's loose, you cannot really put much, it doesn't let you thread more in it. So what I did, again, I put that half a thread in and pushed it back actually against the bone to have some counter rotation measurement, and then I'm able to thread it completely inside of the cage. As you see here, it's going deeper in, and now I'm ready to take it out. But before I do that, I want to have the lower profile of the cage, and with the lower profile of the cage, I'm able to pull that back through the transcambine. And now the question is what to do. I need to put a cage in, but I don't want to put that through the same approach in the same track. So what I do, I go to the contralateral side, to the right side, and I perform a transcambine approach and OLIF procedure from the contralateral side, from the right side. Again, I enter it from the right side, then perform a discectomy. I don't have to do much discectomy because this was already done. And then pack it with tricalcium phosphate. And then literally after that, I'm ready to put a cage. I put a quite large cage. This cage was 15 millimeter, so I go in the lowest profile of the cage, and then once I'm in place, I rotate it 90 degree for, here is the rotation, right here, and now you see that that cage is now in the proper position. Here, that is the rotational action. And these are now our new finals. And patient woke up, leg pain was gone, and most likely can go home today or tomorrow.